Welcome, everyone, to this month's case study. It's all about a woman in her early 20s who may or may not have PCOS. So I titled it, Is It Really PCOS? Because she was diagnosed with PCOS, but as you'll find out, um, it's a little unclear if she actually has PCOS or a different condition that kind of mimics PCOS. So I will say this case study is a little more involved than the other ones I typically do. There's almost 100 slides. It's probably going to be an hour. So hold tight if you want to nerd out on PCOS and if you want to nerd out on all the conditions you need to rule out before diagnosing PCOS, then stay tuned. So thanks for taking some time out of your day to watch this. I hope you learned something new like I have. All right, so this is me. My name is Kelly Ruef. I am a clinical consultant for Precision Analytical, and this is my Instagram if you want to find me online. Okay, the learning objectives. We're going to discuss the diagnosis of PCOS, learn about those conditions we have to rule out before we can diagnose PCOS, and then we'll talk about that case study. Okay, so I like this picture. It's like an avocado with a string of pearls. Just makes me think of an ovary, a polycystic ovary. But so diagnosing PCOS, let's talk about that. So a lot of people still go off of the 2003 Rotterdam criteria. There's a lot of different criteria out there, but the most popular one that people usually go by is the Rotterdam. And the PCOS is defined by the presence of two of the three criteria, oligo and ovulation. So a lot of times you think about irregular cycles with that. Hyperandrogenism, so high androgens, and polycystic ovaries. And you can see here that the Rotterdam criteria says you need to have this 12 or more follicles measuring 2 to 9 millimeters in diameter and or an ovarian volume greater than 10 mils in at least one ovary. So remember, you can't diagnose PCOS solely off of an ultrasound. Occasionally you see that happening, but you also have to look into the androgens, the cycle regularity. Okay, so this study was very interesting because it showed that just because a woman has polycystic ovaries doesn't mean she has PCOS. So they found that so polycystic ovarian morphology, that's PCOM, was present in 39 subjects, and normal ovaries were present in 29 subjects. And this was a study where they did a transvaginal, I believe it was transvaginal ultrasound on 68 women who had regular cycles and no evidence of high androgens. So these women had no evidence of PCOS, and yet they still found 39 of them had polycystic ovaries. So you can still be healthy, you can still not have PCOS and have these polycystic ovaries. This is why we don't diagnose PCOS based off of ultrasound only. So this study talks about how teenagers often have polycystic ovaries. So if you diagnose a teenager with PCOS based on ultrasound findings, it's not ideal because they just tend to have polycystic ovaries more so than adult women. And this study is really interesting. It talks about like we've had improvements in ultrasound resolution. And so a lot of women without PCOS will have an ovary with over 12 follicles. So this this research study was saying, well, maybe we should define it as greater than or equal to 25 follicles instead of 12. So just something to think about. So there's different types of PCOS. We've got the PCOS with ovarian origin of those high androgens. That's the most common. And then we have the type of PCOS where it's more adrenal origin of those high androgens. The adrenals they're overproducing androgens. And that one is less common. Okay, so PCOS is a diagnosis of exclusion. That's always really important because a lot of times we just jump to PCOS. We're like, oh, high androgens, irregular cycles, you've got some facial hair, some acne. Okay, automatically PCOS. But we actually have to rule out some other conditions before we can diagnose PCOS because there's other things out there that mimic symptoms of PCOS. So we'll go through them. This is a good little article, talks about it, but I've kind of summarized it here. I've listed them out. So hypothyroidism can mimic symptoms of PCOS. A lot of times you can see irregular cycles with hypothyroidism, sometimes even amenorrhea. You can see acne, sometimes hyperprolactinemia. So in some types of hyperprolactinemia, you actually see high androgens and symptoms of high androgens. You can see irregular cycles. And then we've got non-classical congenital adrenal hyperplasia. We'll talk about this in more detail, but as you can probably tell, this involves the adrenals overproducing androgens, and it's a genetic disorder. And we have Cushing syndrome. Remember, Cushing syndrome is when we kind of lose that diurnal curve in our cortisol, and we just make high cortisol, just have high cortisol throughout the day. So the adrenals are kind of overproducing cortisol and usually overproducing androgens. And then hypogonadotropic hypogonadism. So that's basically when the brain kind of slows or stops communicating with the ovaries. And with that, you can see some irregular cycles. A lot of times you see amenorrhea. And with that, you usually see low sex hormones. And then androgen secreting tumors. They're more rare, but they happen sometimes. Okay, so what's the first thing we should test in order to diagnose PCOS? Yeah, you probably know. You probably know it's testosterone, right? But did you know that free testosterone, and that's the calculated free testosterone, not the direct measurement of free testosterone, it's a better way to assess testosterone levels in PCOS than total testosterone. And I want you to really understand this. So in PCOS, we tend to have low sex hormone binding globulin. And remember, sex hormone binding globulin will bind up testosterone, leaving less of it in the free form. And it's the testosterone in the free form that's the active hormone. And so if you've got low sex hormone binding globulin, you might have more in the free form floating around, right? So your total testosterone might actually come back normal because total measures all the testosterone that's bound up by sex hormone binding globulin and all the testosterone that's in the free form. It also includes the testosterone bound to albumin. So total testosterone might be normal, but free testosterone might be elevated. And you want to measure testosterone in the morning around 8 a.m. because apparently 10%, it falls by 10% from 8 a.m. to 4 p.m. So if testosterone comes back high, then what do we test? So if there's menstrual irregularities, we want to rule out other causes of anovulation. So we're going to, if we suspect pregnancy, we're going to test the HCG. We're going to do a chronic disease panel, which is pretty basic. This is according to UpToDate. It's pretty basic. It's a CBC, a CMP, and a SED rate. Probably going to do that anyways. We're going to look at LH and FSH. Remember, these are gonadotropins that are released from the pituitary that tell the ovaries to make hormones. And if you look at FSH and LH, you can kind of get an idea of how or what the brain is doing. How is the brain communicating with the ovaries? And so if there's an issue with the brain, then usually you'll see low LH and FSH. But if there's an issue with the ovaries, then a lot of times you see high LH and high FSH because the brain is screaming at the ovaries, "Hey ovaries, make some hormones. Why aren't you making some hormones?" Okay, prolactin. We can look at prolactin. A lot of times with hyperprolactinemia, we will see irregular cycles and high androgens. Not always. Sometimes high prolactin can actually induce a hypogonadotropic hypogonadism state. So basically that means it shuts down the brain's communication with the ovaries. So you'll see that low LH, that low FSH, low sex hormones. And then of course, TSH to look for thyroid disorders. I would argue to do a full thyroid panel like TSH, free T4, free T3, thyroid antibodies, reverse T3. I think a full thyroid panel is important. Okay, so what if all those tests come back within range? Well, Then we need to screen for common non-PCOS conditions that involve high androgens. Okay, sorry, I'm getting a little confused there. So if they all come back within range, then we know that these are not causing the menstrual irregularities, right? So that's more of an argument that, hey, this could be PCOS. So we need to then screen for common non-PCOS conditions that involve high androgens. And these are the tests that we're going to do. We're going to do the 17-hydroxyprogesterone, the DHEAS, the prolactin, which we kind of already did, the cortisol, the IGF-1, insulin like growth factor 1, and the pelvic and abdominal ultrasound. Okay, so what if all of those tests come back within range? Then the patient likely has PCOS. There could be, a rare chance of a rare disorder, but it's likely PCOS. So in that case, we would go ahead and we would treat for the PCOS, right? What if the tests come back abnormal? So if the 17-hydroxyprogesterone, remember you have to measure that in the morning because it drops off throughout the day, and you have to measure it in the early follicular phase. So if it comes back elevated, then we might think of congenital adrenal hyperplasia or non-classical congenital adrenal hyperplasia. Remember, these are genetic disorders, or maybe even some sort of tumor. If DHEAS comes back over 700, then we're thinking an ovarian, possibly adrenal tumor. Just know that these ovarian and adrenal tumors, they don't always present with high androgens or high DHEA. You could still have a tumor and not have DHEA over 700. But as a good rule of thumb, if your DHEA comes back that high, then you're probably going to want to look into like an ultrasound to rule out a tumor. And then, of course, elevated DHEAS can also be seen with the 3-beta HSD form of that non-classical congenital adrenal hyperplasia. And we'll talk about that a little bit more. So if prolactin comes back over 25, then we're thinking maybe some sort of prolactinoma. And right down here, I wrote that high prolactin can present with or without high androgens. And high prolactin and high androgens usually also present with galactorrhea. And you'll see our case study is on a woman named Samantha, and she actually did report nipple discharge. So that's interesting. High prolactin may present without high androgens if it induces that hypogonadotropic hypogonadism. And remember, that's when the brain just like doesn't communicate with the ovaries. That LH, the FSH signaling goes way down, and the brain just kind of stops communicating with the ovaries. So the ovaries don't make much sex hormones. If cortisol is elevated, then we're thinking maybe Cushing's. If insulin like growth factor 1 is elevated, maybe acromegaly. And then the pelvic and abdominal ultrasound abnormalities. Of course, if there's PCOM, then we're thinking PCOS. But if there's some other mass, there might be some sort of tumor. So when we do the ultrasound of the ovaries and the adrenal glands, it can help to detect tumors in the ovaries and the adrenal glands. It can also look, of course, for the PCOS, the string of pearls, the polycystic ovaries that we see with PCOS. I like this little excerpt from Up to Date because it's not like if you've got a woman who's got irregular cycles and she's got high androgens, it's not like you're going to automatically do an abdominal ultrasound to rule out an adrenal tumor. So they say some of the experts reserve the ultrasound screening for patients with these atypical features, like rapidly progressive hirsutism, enlarged clitoris, or hirsutism or menstrual abnormality that fails to respond to therapy, or if there's like really high testosterone or high DHEA. And so a testosterone over 150 nanograms per deciliter increases the likelihood of that ovarian and adrenal tumor. And then the DHEAS over 700 increases the likelihood also. So that's pretty high levels. So what are some other tests we can use to differentiate PCOS from other conditions that present with high androgens? These ones probably haven't heard of. They're not done that often, but it's really interesting to know that they exist and know how they work because they really can help you differentiate PCOS from other conditions. So one of them is the dexamethasone androgen suppression test. And remember, dexamethasone is a really strong glucocorticoid and it suppresses adrenal output. So remember when you take exogenous steroids, exogenous glucocorticoids, they're going to suppress your own endogenous production of cortisol because your body doesn't want too much glucocorticoid activity, right? And so if you can imagine, if you take a bunch of dexamethasone, if it suppresses your adrenals, it's going to suppress your cortisol, but it's also going to suppress your androgens, right? So if you have an issue that involves the adrenals overproducing androgens, then this dexamethasone test is going to suppress the adrenals and those androgen levels are going to come down. But if it doesn't suppress the androgens, so if you take a bunch of dexamethasone and it doesn't suppress the androgens, then you know, okay, those high androgens are probably not from the adrenals, they're probably from the ovaries, right? So I'll let you read through this if you want more detailed information. And then there's the ACTH stimulation test. And remember, ACTH is the hormone that's released from the pituitary and it goes to the adrenals and tells the adrenals to make cortisol and to make DHEA. So if you take ACTH, you should see an increase in cortisol and DHEA. But in some cases like this non-classical adrenal hyperplasia, if you take the ACTH, your adrenals overrespond and they just make a ton of this 17-hydroxyprogesterone. So I'll let you read through this too if you want to learn more. You probably won't come across this very often, so it might not be that important to understand, but I think it is interesting. If you want to really understand PCOS and how it's diagnosed, read through this. Okay, some other interesting notes about diagnosing PCOS. So oral contraceptive pills can suppress testosterone production and should be stopped for 2 to 3 months prior to doing a workup for PCOS. Remember, oral contraceptive pills, the way they prevent pregnancy is by shutting down that brain's communication with the ovaries. So they usually lower the sex hormone production from the ovaries. So lower testosterone, right? And then hirsutism can be caused by medications such as anabolic steroids and valproic acid, which is used to treat epilepsy. So you always got to rule that out. Okay, let's talk about our case study here. So this is Samantha, and she's in her early 20s, and she struggles with a lot of symptoms that you would see with PCOS: irregular cycles, occasionally heavy periods. She's got acne, anxiety, and some bloating and abdominal pain. She's been diagnosed with PCOS via ultrasound. So they saw the string of pearls, they saw those polycystic ovaries, PTSD since her late teens, which might kind of play into the anxiety and the bloating and abdominal pain, and generalized anxiety disorder. She's got a history of anorexia, diagnosed at 17. She said she was amenorrheic for a long time, so she didn't get a period for a very long time. But then when she started recovering from the anorexia, she got her period, but they're irregular. And she's currently vegetarian, leaning towards pescatarian, mostly vegetarian. She's sensitive to gluten and dairy, so she's cut that out of her diet. Her BMI is 22.9. It's pretty good. Normal is 18.5 to 24.9. These are her medications. She's on this mini pill. And remember, a mini pill is a progestin-only pill. And she's not taking it for birth control. She's taking it to help regulate her cycles and her symptoms. So her doctors have put her on various different oral contraceptive pills, hoping it'll help her symptoms. But every time she takes them, she's like, no, I just feel worse. So she's also on Zoloft and hydroxyzine, probably for the anxiety, the PTSD. And these are her supplements that she's taking. I do want to point out she's taking a high dose iodine. And I don't usually use high dose iodine. We did a little bit in my residency, but I don't usually use high dose iodine, especially if they have thyroid antibodies. So I'm going to ask her, were you worked up for thyroid antibodies? Because if she's got thyroid antibodies, we definitely don't want to give too much iodine. All right, does she truly have PCOS? That is the big question, right? So my first question in answering that question is, when was the ultrasound that diagnosed the PCOS performed? In her teens? Are those results reliable in order to diagnose PCOS? Remember, if you're a teenager, you're more likely to have those polycystic ovaries. My second question, does she have high androgens? That's the first thing we have to test, right, for PCOS is androgens. So let's look at her Dutch Plus results. So this is page 1 of her Dutch Plus, and it's more of a summary page, but we can automatically see, look at that, high testosterone. When this dial's in the red, it means it's high. It's too high. Look at this total DHEA, above range. So this is page 3 of a Dutch Plus. And remember, for progesterone and estrogen, if you look at these dials, in between the two stars is the luteal range. Remember, we want women to collect in their mid-luteal phase, about a week before they get their period, or about a week after they ovulate. And then this little purple band, that's the postmenopausal range. So her progesterone, if we look at her progesterone metabolites are within range, despite being on the mini pill. So it's interesting to note that a combination oral contraceptive pill usually has the ethinyl estradiol, so it's got a synthetic estrogen, and it's got a progestin. The combo OCPs will shut down the brain's communication with the ovaries. So it'll shut down ovulation. But the mini pill is just progestin, and it doesn't always shut down ovulation. So in this cycle, she still ovulated. And remember, the progestins, the synthetic hormones, we don't measure those on the Dutch test. Like the Dutch test will not pick up those progestins. So this progesterone here, that's her endogenous progesterone, the progesterone she made. One note about her oral contraceptive pill. So she is taking the mini pill. It's got norethindrone, which is a progestin. And let's go all the way down to this bottom little point here, bullet point here. So norethindrone is a progestin, synthetic progesterone, right? With a high androgen index. So this means that it can act like an androgen in the body. So it's probably not going to help her symptoms of androgen excess. So sometimes we see this. We see women with PCOS and they're given the mini pill with a progestin that has a high androgen index, which is not great. It's probably not going to help their symptoms. It's not going to help their acne, for example. And so we're probably going to want to take her off of that. So these are her estrogens. We can automatically tell they're above range, right? They're high for the luteal phase. And her phase 1 metabolites, they're all above range too, right? And that's because her parent hormones, her E1 or E2, are above range. So her estrogen metabolites are going to be above range too. But luckily, if we look at this pie chart, you can see the relative ratios of the phase 1 metabolites. They're all within range. They look really good. So remember, phase 1 metabolites, they're all a little reactive, a little rowdy. They can cause oxidative damage and inflammation in the body. So you don't want any phase 1 metabolite to stay in phase 1 for too long. You want them to move over to phase 2, where they're more stable, they're more water soluble, they're more ready for excretion. So she's metabolizing most of her estrogens down this protective pathway towards the 2OH. We call it the protective pathway. You could also call it the least damaging pathway because the 2-OH, remember, it's a phase 1 metabolite. So it can still cause damage in the body. It's just not going to cause as much damage as like the 4-OH, which is the one we worry about for risk for breast cancer. Okay. And her methylation activity, remember this is phase 2. So 2-OH and 4-OH, they both get methylated in phase 2 and cleared out of the body that way. Her methylation activity, you see this little red dial is pointing to the right towards high. So that's good. So she's clearing out her estrogens in phase 2. At least this one pathway that we measure, she's clearing her estrogens out adequately. Okay, but we really want to look at the androgens, right? Because we're suspecting PCOS. So here we got 4 androgen metabolites here on page 3. There's 3 that pertain mostly to DHEA. So DHEA can be sulfated to DHEAS or metabolized downstream to etiocalanolone and androsterone. And so we have these age-dependent ranges, and I highlighted her range. So we can see, I mean, okay, first of all, if any dial is in the red, then you know it's just high for any age. So I know her DHEAS is high for any age. I know her androsterone is high for any age. Her testosterone is high for any age. Her etiocalanolone, you know, if we look at this reference range here, it's getting towards the high side. And if you look at her 5-alpha reductase activity, she is pushing the alpha pathway. So remember, when we say you're pushing the alpha pathway, what it means is that you're pushing a lot of your androgens, the majority of your androgens like testosterone or DHEA, you're pushing them down 5-alpha reductase, the more potent pathway. So 5-alpha reductase turns your DHEA and your testosterone into these more potent, more androgenic metabolites. Whereas 5-beta reductase will push your androgens into these less potent forms. So if you favor the alpha pathway, you're going to have more potent androgens. So your body's going to feel the effects of more androgen activity, basically. And in the research, we see that women with PCOS tend to favor the alpha pathway. I thought that's pretty interesting. So on page 2, we have a few androgens on page 2 that are not on page 3. So I like to kind of, point them out. And here, 5-alpha DHT, remember 5-alpha DHT is the active form of testosterone. So this 5-alpha DHT is like 3 times more potent than testosterone, and hers is above range. And then DHT gets converted to 5-alpha androstenediol. And there's some research showing that 5-alpha androstenediol might actually be a better marker of DHT levels in the tissue than looking at the DHT in the urine or the serum. So a lot of times I'm looking at this 5-alpha androstenediol marker also, and hers is above range. So, she's probably got some high androgens in her tissues. It's probably causing the irregular cycles, the acne. All right, so then here's the big question. Have we ruled out other causes before diagnosing PCOS? And here's a list of those, right, that we need to rule out. So I automatically kind of ruled out hypogonadotropic hypogonadism, because remember, that's when the brain just doesn't really send a signal to the ovaries. So that LH, the FSH signaling goes down. So the ovarian production of hormones goes down. But we can see with her result, like she's making plenty of hormones, right? So don't think it's that. But what about the other ones? What about her prolactin? What about her thyroid? So let's do a blood draw. So these are her lab results. And here, remember that what we were talking about for measuring testosterone and PCOS, they said free testosterone is actually a better marker than total testosterone. They do say, if you only have access to total or there's an issue with being able to afford free testosterone, then just start with total testosterone. But in general, free testosterone is going to be a better marker. And remember to get the calculated free testosterone, not the direct measurement. So her total testosterone was actually 44, which is within range, but her free testosterone was getting a little high, a little bit above range. Sex hormone binding globulin was normal. Her DHEAS in the serum was normal, but in the urine, we are seeing it above range. Prolactin is slightly high. So she's got some high prolactin. This is a really interesting one. Her pregnenolone was really high. We'll talk about that more later. But that 17-hydroxyprogesterone, remember we test that to rule out the congenital adrenal hyperplasia or the non-classical congenital adrenal hyperplasia, those genetic disorders. Hers was normal. But if you look at her TSH, it's definitely high. It's above range, above the conventional range, and her free T4 was low. So she does have some hypothyroidism. Her blood sugar results all came back pretty normal, which, with PCOS, sometimes, especially if it's ovarian, if the high androgens are from the ovaries, a lot of times you'll see blood sugar issues. Not always, but a lot of times you do. And then her iron panel here just is showing low iron overall. So that's a little curious. Maybe, she says occasional heavy bleeding. Sometimes women will lose iron through bleeding. All right, so we know she's got hypothyroidism. We know she's got slight high prolactin. And then not so sure about this non-classical congenital adrenal hyperplasia. Her 17-hydroxyprogesterone was below 200. So if it's above 200, then you start thinking, oh, okay, congenital adrenal hyperplasia. But the weird thing is her pregnenolone is so elevated. And in some of the adrenal hyperplasias, you can see high pregnenolone. I can't think of anything else where you would see high pregnenolone. So I'm a little suspicious that there might be this adrenal hyperplasia. Cushing syndrome, not so sure. And these secreting tumors, maybe. They're a little more rare. Okay, let's talk about non-classical congenital adrenal hyperplasia. I know it's exactly what you want to talk about right now, right? Because it's confusing. A lot of people haven't even heard of it. And it's important to rule this out when women have these symptoms of PCOS, because it might not be PCOS. It might actually be this adrenal hyperplasia. So they're congenital disorders. They're genetic. And the most common one is due to this 21 hydroxylase deficiency. Let me see if I can skip ahead here. Okay, so if you look at the steroid chart here, we can see cholesterol, parent hormone, goes down to pregnenolone. And then pregnenolone goes down to like progesterone, cortisol, over to DHEA, testosterone. So all of our sex hormones and cortisol are coming from cholesterol and pregnenolone. But you can see there's an enzyme right here and right here that converts progesterone to deoxycorticosterone and then 17-hydroxyprogesterone. Remember, that's what we test in the serum. It converts that down to cortisol. So to rule out the non-classical congenital adrenal hyperplasia due to the 21 hydroxylase deficiency, which remember is the most common type of NCCAH, we have to measure the 17-hydroxyprogesterone, this guy here, in the early follicular phase. So think around cycle day 2 or 3, and we have to do it in the morning around 7:30 to 8 a.m. And that's because if you do it later on in the day, it's just inaccurate because those levels can rise as the day goes on. Or maybe they can fall, I forget. So a normal result is below 200. And if we go back to this slide, so there's the congenital adrenal hyperplasia, and then there's the non-classical congenital adrenal hyperplasia. And the congenital adrenal hyperplasia, that one is usually diagnosed in the neonatal period, when we're really, really young. And they usually have adrenal insufficiency, salt wasting during infancy, or virilization, so a lot of kind of androgenic traits like hair growth, enlarged clitoris, that kind of stuff during the first few years of life. But the non-classical congenital adrenal hyperplasia, this is a less severe form of this disorder, but this is the one that's usually diagnosed more in adulthood. So that's the one that's usually on my radar. And there's some really interesting facts here around it. Let's see what the most important ones are. You can read through them, but let's see. So prevalence of the non-classical congenital adrenal hyperplasia is 1 in 1,000 or possibly even 1 in 100. That's like way more prevalent than I thought before. So it is important to rule this out before diagnosing PCOS. And it's often misdiagnosed as PCOS, as you can imagine, because if you look at this, if you're not converting down towards cortisol and aldosterone, then your 17-hydroxyprogesterone builds up, but your androgens also build up because you're kind of diverting all your pregnenolone to your androgens. So common symptoms with this NCCAH that's diagnosed in adulthood is hirsutism, oligomenorrhea, and acne, which, it's like what we see with PCOS. Okay, so an adult woman, in order to rule out the NCCAH due to that 21-hydroxylase deficiency, is we measure that 17-hydroxyprogesterone. And like I said before, we must measure it in the early follicular phase. If you do it in the luteal phase, it's common to have elevated 17-hydroxyprogesterone. Because remember, it's like the precursor to progesterone. So if you ovulated, of course, your 17-hydroxyprogesterone is going to increase because your progesterone is increasing. So early follicular phase. And then we must measure it in the morning, 7:30 to 8 a.m., because the levels decline over the course of the day. Okay, there we go. So 17-hydroxyprogesterone declines throughout the day. So if you measure it at 4 p.m., you might miss it. You might say, oh, it's normal. It's under 200, but you actually just missed it. You didn't measure it in the morning. And so if your 17-hydroxyprogesterone comes back over 200, then you're going to do that ACTH stimulation test. And if you take the ACTH and your 17-hydroxyprogesterone is over 1500, it's pretty high, then that's diagnostic. Then you can diagnose NCCAH. If it's between 1,000 and 1,500, it's a little inconclusive. So you want to do some genotyping. It's the CYP21A2 gene in order to diagnose this condition, this genetic condition. So remember, our patient had a normal 17-hydroxyprogesterone, but it's unclear to me if the measurement was taken in the morning. So I'm going to repeat it. And her pregnenolone was almost 3 times the upper limit. So there's other types of NCCAH with different enzymatic deficiencies. So there's a 3-beta HSD deficiency, and with that, we can see high pregnenolone. So her DHEA, we'll also see high DHEAS with the disorder, with the 3-beta HSD deficiency. Samantha's DHEAS on the Dutch test was elevated, but her DHEAS in the serum was within range. So we're going to repeat the pregnenolone and the 17-hydroxyprogesterone and then refer to endocrinology if they're elevated, just so they can rule out the non-classical congenital adrenal hyperplasia. And if she is diagnosed with this genetic disorder, then they can treat it, because I don't have experience with that. Note that the 3-beta HSD, like this form of the NCCAH, is pretty rare, but it happens. So here we can see the same steroid chart, and here's the 3-beta HSD enzyme. So you can see if this enzyme isn't working, pregnenolone is going to build up in the body, right? And DHEA is going to build up in the body. All right, so we've diagnosed hypothyroidism, we've diagnosed hyperprolactinemia. Still not so sure about the NCCAH. We're just going to repeat the 17-hydroxyprogesterone and the pregnenolone. We're going to do it in the morning, in the early follicular phase. We're going to do it right? Make sure that it was done right, because I'm not sure if it was before. It's usually good to repeat them anyways. If you get like a weird result like that, that could lead to a diagnosis. You probably want to repeat it. So does she have Cushing syndrome? Well, let's look at her adrenal panel on her Dutch Plus. We can actually look at the Dutch Plus to get an idea of, could there be Cushing's? Usually with Cushing's, you'll see the metabolized cortisol above range. Remember, this marker tells you total cortisol production. So usually in Cushing's, people are just overproducing cortisol. And usually people will lose their diurnal rhythm and you'll just have high cortisol in the free form, in the saliva or in the urine. Usually these dials down here are above range. She still has a diurnal rhythm. Like generally it's higher in the morning, lower at night. I actually think that maybe she switched her waking and her 30-minute samples. It would make a lot more sense if she did. But we can rule out, we can't, the Dutch test isn't diagnostic, but we can look at this and say, okay, probably not Cushing's. I'm going to scratch that one off. Okay, and then the androgen secreting tumors. For now, I feel like we have enough evidence of things that could be causing her symptoms that I'm not going to put her through like an additional ultrasounds, right? So why is her prolactin elevated? Remember, she had some slightly high prolactin. And this is fascinating. So patients with hypothyroidism, when you have low thyroid hormone, let me go to the next slide. This is probably better. So if you have low thyroid hormone, it actually feeds back to the brain, to the hypothalamus, and the brain releases more of this TRH. And remember, the hypothalamus releases TRH, and TRH goes to the pituitary and tells the pituitary to make more TSH. And what does TSH do? It goes to the thyroid and tells the thyroid to make more thyroid hormones, which would make sense if you had low thyroid hormones. But a lot of people don't know that TRH also tells the pituitary to make prolactin. So if you have high prolactin, it can be from hypothyroidism. And there's this one study that showed that estrogen mediates this by enhancing the effect of TRH and inhibiting that of dopamine. Basically, what this is saying is if you have high estrogen, it can actually enhance the effect of TRH on the pituitary and lead to higher prolactin. So with higher estrogen, it might induce higher prolactin too. And she had some high estrogen, remember? This is a study, it kind of talked about the link between PCOS and hyperprolactinemia. So there may be a link between PCOS and hyperprolactinemia, but it's not very clear. And not all women with PCOS have high prolactin. So I'll let you read through this if you want to later. So let's ask again. Okay, why is her prolactin elevated? So her prolactin is elevated most likely because she's got hypothyroidism, right? But these are some other, possibilities. Maybe she's got low dopamine. Maybe she's got high estrogen, which she does. Maybe she's got high GnRH pulsatility, which the GnRH pulsatility is going to affect ovarian output of hormones. Okay, so why are her androgens elevated? Well, first of all, let's talk about where are androgens produced in cycling women. And if you look here, you'll notice the adrenals make the majority of our androgens. So in a healthy woman, her adrenals are making more androgens than her ovaries. It's a fun fact of the day. So what contributes to elevated androgens? Well, we can have high ovarian output. We can have high adrenal output. We can have stress. Stress usually increases adrenal output. High body fat percentage, insulin issues, low sex hormone binding globulin, all of these issues that we've been talking about a lot, right? They all contribute to elevated androgens. Sometimes, if you have a partner who's using testosterone cream and then you hug them, that testosterone could get on your skin and elevate your androgens if it absorbs. And then, of course, if our liver and our gut, if we're not able to clear out our androgens, our sex hormones, they can elevate in our body. They can back up in our body. Okay, let's talk about hyperprolactinemia and how it causes high androgens. So high prolactin usually leads to high androgen production through the adrenal glands. This is a really interesting study. It just says that the prolactin increases ACTH. Remember, that's the signal that goes from the brain to the adrenal glands to tell the adrenals to make cortisol and to make androgens. So when you have high prolactin, it increases that signal and it can cause the adrenals to kind of grow in size, get bigger. So they'll make more androgens. And high prolactin, they think it increases the adrenal cortex sensitivity to ACTH. So then it's more sensitive to the signaling. So even, if you've got a certain amount of signaling, you're going to over respond and make too many androgens in response. And then prolactin has been found to increase levels of adrenal androgens, DHEA, DHEAS. So let's ask again, what's contributing to her elevated androgens? Well, a lot of things probably. I've circled the things that I think are contributing. I think she's got high adrenal output. She's stressed out. She's got anxiety. She's got PTSD. We know she's got thyroid issues. We know she's high prolactin. And remember, if you have high prolactin with high androgens, a lot of times you'll have that nipple discharge, which she does. She might have PCOS. It's a little unclear to me. And suboptimal clearance in the liver and the gut. So hypothyroidism can lower basal metabolic rate and can lower liver function. But maybe even with I wonder about her eating patterns and if she's eating enough calories now. Because if you're under eating, that can slow down your clearance, your detoxification pathways, right? Okay, so does she have PCOS? Or are her issues stemming from the hypothyroidism and the high prolactin? So she might have PCOS. Like she meets all three of the Rotterdam criteria. She's got the irregular cycles, she has the high androgens and the polycystic ovaries, which they found on ultrasound. But, you know, it's a little uncertain because her pregnenolone came back high. So I'm thinking, does she have that genetic disorder, that non-classical congenital adrenal hyperplasia? I don't know. Let's repeat 17-OHP. Let's repeat pregnenolone. And if it comes back high, I'm going to refer her to endocrinology. So I think her symptoms are most likely due to a combination of hypothyroidism, hyperprolactinemia, and possibly primary functional adrenal hyperandrogenism. So that's the PCOS with the adrenal origin. And that's because her blood sugar markers are within range. A lot of times, if there's blood sugar issues, it's more high androgens from the ovaries. I mean, not always, but so I said it is possible though that maybe she doesn't have PCOS. Maybe her irregular menses are due to that hypothyroidism. Maybe her polycystic ovaries are actually normal for her. Maybe they're polycystic because she does have high androgens, like that. When you have a high androgenic environment in the ovaries, it can cause those follicles to not be able to choose a dominant follicle. So usually during the menstrual cycle, you have a cohort of follicles, right? And then one of them becomes the dominant follicle, and all the other follicles kind of wither away and die. And then you have one follicle that makes one egg that maybe one day will be fertilized and implanted. But when you have a high androgenic environment in the ovaries, it doesn't allow for the dominant follicle to be chosen. So you end up with just a bunch of small follicles. Um, it is good to note that in severe hypothyroidism, you can see polycystic ovaries. She doesn't have severe hypothyroidism. Maybe the acne is coming from the hypothyroidism and the high androgens. And maybe the high androgens are coming from that high prolactin. She had the nipple discharge too, so possible. And the high pregnenolone finding is just so odd. I can't get over it. So we're going to repeat that and send to endocrinology. And it's possible if we treat her thyroid, her symptoms might resolve. Remember, hypothyroidism can induce hyperprolactinemia, which can lead to high androgens. So if we correct her thyroid, her prolactin might normalize, and that might help her androgens normalize. So if we treat her thyroid and she just gets better and better, her symptoms get better and better, that's a big sign that her symptoms might be stemming from hypothyroidism. So could the hypothyroidism be the cause of her high androgens? So it's important to note that hypothyroidism can cause PCOS-like signs and symptoms. Like when you have hypothyroidism, you can have irregular cycles and you can have acne. You can have coarsening of your hair, which might be confused with hirsutism. And with hypothyroidism, it tends to lower sex hormone binding globulin, right? So it can increase the amount of free active testosterone. And in the severe cases, you can get the polycystic ovaries. Um, so we have to rule it out before we diagnose PCOS, but we usually, this is not always, but usually with hypothyroidism, you see low sex hormones. So I think maybe she has PCOS, maybe the NCCAH, or maybe the high sex hormones are just due to that prolactinemia, the hyperprolactinemia. So it's a little unclear. Could her high prolactin be the cause of her high androgens? Yeah, it's totally possible. If the thyroid medication brings her prolactin back within range, and if her androgens lower, if her testosterone lowers, if her DHEA lowers, then that's evidence that the high prolactin was leading to the high sex hormones. And thyroid medication hopefully will also help improve her metabolic rate and her liver function, right? So it'll hopefully help the body detox and help the body clear out hormones more efficiently. So maybe it'll help her kind of get rid of the excess estrogen, the excess androgens also. Okay, so let's correct her thyroid, right? But first, why might she have hypothyroidism? And I wanted to point this out that undereating can lead to low thyroid hormones. And she has a history of anorexia. It's unclear where she's at in her healing journey with that. But this study showed that even people who had 1,200 calories a day, which, a lot of people are eating 1,200 calories a day, it can show reductions in T3 as great as 40%. That's insane. So if you're under eating, it can slow down your thyroid. You can become hypothyroid. So, she struggled with anorexia, so we should probably just make sure she's eating enough now. We kind of ask more questions around that, maybe refer her to a counselor that specializes in eating disorders to help her there, cuz I wouldn't I wouldn't want to give thyroid hormone to a woman who's anorexic, because when you're anorexic, it's already setting you up for bone health issues. But if the anorexia is severe enough, usually you'll see low hormones, low sex hormones. So, okay, so let's look at her organic acids. These are on the last page, page 6 of the Dutch Plus. And the only one that's a little out of range is her MMA. And remember, methylmalonic is a B12 marker. You need B12 to convert MMA to succinyl-CoA. So if your B12 is low, your MMA is going to back up in your body. So these are the summary of our findings. She's got normal progesterone, so she ovulated. She's got high estrogen. She's got healthy estrogen metabolism patterns. That's good, right? At least she's got that going, which is awesome. She's got high androgens with that 5-alpha reductase preference, which common in PCOS. She's got this high normal cortisol, low end B12, this hypothyroidism picture, high prolactin, high pregnenolone, and then low iron, low ferritin. And remember, we need healthy ferritin levels in order to activate T4 to T3. So maybe this low iron has something to do with her thyroid function. Maybe if we improve her iron, her thyroid function will improve. So here are some additional labs that we're going to do. We're going to do just some basic complete blood count, comprehensive metabolic panel. I might want to look at, like, these tests are around cardiovascular health, because in PCOS, you see an increased risk of dyslipidemia, metabolic syndrome, and cardiovascular disease. You can also see those issues with hypothyroidism. So I might kind of want to work her up for her cardiovascular health. I'm going to keep an eye on her blood sugar markers. because with PCOS, you have an increased risk of type 2 diabetes, right? Might look at her LH or FSH. Remember, those are the signals from the brain to the ovaries that tell the ovaries to make sex hormones and to ovulate. Her estradiol, possibly the AMH. So AMH is usually above 3 in women with PCOS. Between 1 and 2 is normal, and if you're below 1, that's not great. Then you start thinking more about like ovarian issues. So we're going to repeat the prolactin, the pregnenolone, and the 17-hydroxyprogesterone. It's interesting to note that prolactin, so they say if prolactin comes back a little high, repeat it and make sure it's fasting, because who knew a high protein meal can increase prolactin. And we're going to repeat the thyroid. Before I prescribe these hormones, I just want to make sure that there's actually hypothyroidism. It'll probably come back similar as hypothyroidism, but I also want to look at the thyroid antibodies, right? But another note, like she's got a lot of anxiety, and sometimes when you add on thyroid hormone, it makes people even more anxious. So I would hate to do that. And then we might refer to endocrinology. So we talked about that. So here's the sample treatment plan. So referral to endocrinology if the 17-hydroxyprogesterone and the pregnenolone come back elevated. We're going to stop that mini pill. Remember that mini pill had that progestin with the high androgen index? We're going to stop that. It's probably not helping her acne. We're going to stop the high dose iodine, especially since we don't know if she's got thyroid antibodies. We're going to put her on a multivitamin. And I kind of pointed out all the things in here that could be helpful for her. So vitamin A, D3, K2, we need these 3 supplemented together in order to best support the body. And K2, it's often low in vegetarians. So I'm oftentimes giving K2 to vegetarians. Remember, K1 is different. K1 you can get just from like a little bit of lettuce, a little bit of greens. People are usually not deficient in K1. It's the K2 that people are usually deficient in because that comes from more like fermented foods. Okay, so I like this supplement. It has a robust amount of B vitamins, including B12, which she might be a little low in. The choline is often low in vegetarians unless they eat eggs. And actually, choline consumption, if you look at the research, most people are not getting enough choline in their diet. And choline is so important for liver, for your brain, for your fetus, if you're pregnant, for your parasympathetic nervous system. And then it's got the iodine, the zinc, the selenium, and then inositol to support her thyroid, and a small amount of antioxidants, which can be helpful for PCOS or even the thyroid. So we're going to do this B12 liquid. So she was diagnosed, I didn't tell you this, but she was diagnosed with hypochlorhydria, low stomach acid. And so we need stomach acid to absorb B12. And so if someone has low stomach acid, you want to give them like a B12 injection, or you want to give it in the sublingual form, because then that bypasses the gut, kind of goes directly into the blood. We're going to add on some Floridic, some blood builder. These are kind of more natural forms of iron that I feel work really well. So we're going to try to get that iron up, which actually might help her thyroid. And then mental health, acupuncture, we're going to do once a week for 3 months. That might be a little intense for her. We'll see if she's able to do that. That could really help. The cortisol relief by Vitanica. If you look at these, they have a lot of really calming products in there, like L-theanine, really calming. Phosphatidylserine tends to help lower cortisol. Ashwagandha, it's an adaptogen, can be great for stress, great for anxiety. Lemon balm, great for depression. There's some mushrooms in there. Okay. And then Relax Max. So Zymogen makes this product, and it also has a lot of really calming ingredients. And it also has myo-inositol. So myo-inositol, we know from the research, can help regulate thyroid function. And the research has been shown to help with Hashimoto's. So here's the summary treatment plan. And I wanted to say, Another option would be, so first, support the thyroid and ensure she's eating enough. Improve her iron and supplement with the selenium, the zinc, the iodine, and the myo-inositol, just all to support her thyroid, or you could just give her thyroid medication. And if the symptoms resolve and the test results normalize, then we know that hypothyroidism is the culprit. We don't even have to worry about referring to endocrinology, right? But if not, if things don't normalize, then we might refer to endocrinology. So these are the goals of the treatment plan. Kind of just wanted to write this out for you so that we can kind of look at the summary. But we want to rule out that genetic disorder, that non-classical congenital adrenal hyperplasia. And we want to ensure adequate caloric intake before we prescribe that thyroid medication or before we start just going ahead and treating PCOS. As I said before, we could just start supporting her thyroid, and if all her symptoms go away, then we don't have to worry about the endocrinology referral. If all of those test results of the pregnenolone comes back normal and the 17-hydroxyprogesterone comes back normal, then we might not have to refer to endocrinology. We're going to replenish her nutrients, support her thyroid, do things to reduce that stress, that anxiety, and then remove that medication, that progestin, because it could be worsening those androgen excess symptoms. We're going to investigate if she's got any blood lipid issues, cardiovascular disease, markers that are kind of out of whack, because that's often seen with PCOS. So if she does have PCOS, even thyroid, hypothyroidism, you see it. So we want to just rule that out. And in the end, if she actually does have PCOS, then the nutrients, the thyroid support, the adrenal support, the stress reduction, and stopping that progestin that had the high androgen index could all be helpful. So a lot of things that we're going to start out doing could help PCOS. Okay, so I know that was a lot of information. It was really detailed. Thank you so much if you made it to the end. I hope you learned something new. You can always rewatch this. Just stop, take notes. And of course, if you have any questions, email us at info@dutchtest.com. Find me on Instagram. I will say I'm a little slow to respond on Instagram, but you can always email this. This will get to me faster. Thanks so much for watching and have a great day, everyone.